Assalamu alaikum and good day. Today we are going to look at neoplastic diseases of the bones and with a little note of soft tissue tumors at the end. We're going to look at general approach to the bone tumors. The most important information for the diagnosis of bone tumors are age, anatomic site, and the part of the bone involved by the tumor. In age, we see that most of the bone tumors, the primary bone tumors, occur in the young age. This is where, because the body is growing, the bones are growing, and the cell proliferation is at its maximum. Anatomic site, we see that most of the tumors are around the knee joint, where the femur and the tibia is located. So this is because the femur is the longest bone in the body and the tibia is the second longest bone in the body. So this is where the maximum proliferation of cells are occurring. The part of the bone that is involved by the tumor is usually in the metaphysis, although we do see tumors at the diaphysis and the epiphysis. The metaphysis is also the location of the cell proliferation. Other consideration that we have to see includes tumor behavior, whether it is benign or malignant or in between. Most of the bone tumors that we see are benign. Ability to differentiate is an ability for the bone tumor to turn from benign initially to a malignant tumor along the way. And association with damaged bone, some bone tumors are associated with some damage to the bone, such as fractures or radiation. Some bone tumors are associated with pain, and there are radiological features, specific radiological features that are associated with some bone tumors. When we look at the location of the common bone tumors, there are a few tumors that are usually found in the diaphysis, such as Ewing sarcoma, fibrous dysplasia, and osteoid osteoma. Most bone tumors are found in the metaphysis, such as osteosarcoma, chondrosarcoma, fibrosarcoma, osteoblastoma and chondroma, fibrous dysplasia, and osteochondroma. Only a few bone tumors is usually found in the epiphysis. Only two, the most important two, are chondroblastoma and giant cell tumor of the bone. Benign tumors are far more common than malignant ones. The most common benign tumors are osteochondroma, non-ossifying fibroma, and enchondroma. Some primary bone tumors are difficult to classify as benign or malignant. For example, giant cell tumor of the bone is very aggressive locally but only rarely metastasizes. World Health Organization classify it as benign. Among primary malignant sarcoma, osteosarcoma have the highest incidence, followed by chondrosarcoma and Ewing sarcoma. One important feature of bone tumor is its ability to dedifferentiate. Some tumors can dedifferentiate. It turns from a benign tumor to a malignant tumor. For example, enchondromatosis may transform into a high-grade sarcoma, usually a chondrosarcoma. There is a tendency of bone neoplasia to arise in damaged bone, sometimes at the site of bone infarcts or radiation or previous area of Paget's disease or areas of chronic osteomyelitis or metal prosthesis. But note that this accounts for only a small fraction of the bone tumors. Benign non-growing lesions tend to be asymptomatic incidental findings. Some tumors produce pain or are noticed as slow-growing mass. Pain may be a symptom of growing lesions or locally aggressive lesions such as giant cell tumor and malignant tumors, pathologic fracture in a benign or malignant tumor, or a significant local tissue reaction to the tumor. bone tumors have relatively specific radiographic presentations on plain X-ray. For example, osteosarcoma has this Codman's triangle feature, and Ewing sarcoma has this onion skin feature. X-ray is usually the first imaging technique for a suspected bone lesion because it's inexpensive and easily obtainable, and it's best for assessment of general radiological features of the tumor. So we've looked at all the general features of the bone tumors from age, anatomic site, part of the bone involved by the tumor, its behavior, ability to differentiate, association with damaged bone, pain, and the specific radiological features. The diagnosis of the bone tumors have to integrate all these clinical features, the radiological features, and the histopathological appearances. So, but the histologic grade is the most important prognostic feature of a bone sarcoma. Now we look at the classification of bone tumors. We classify them into whether they are bone forming, cartilage forming, fibroblastic, or others. And we also classify them into their behaviors, whether they are benign or malignant. So bone forming benign tumors are osteoma, osteoblastoma, osteoma, and the malignant bone forming tumor is osteosarcoma. Benign cartilage forming tumors are osteochondromas, chondromas, and chondroblastomas, while the malignant counterpart is chondrosarcoma. We see benign lesion that forms fibroblasts is fibrous dysplasia, and the malignant counterpart is fibrosarcoma. In others, we see the aneurysmal bone cyst, ABC, and giant cell tumor, and malignant is Ewing sarcoma. We look at osteoid osteoma. It usually occurs at a young age and usually affects the long bones seen at the diaphyses. Males are affected more than females. Presents with bone pain usually at night, and the pain is relieved by aspirin. This is caused by excess prostaglandin E2 produced by the proliferating osteoblast. The tumor size is usually less than 2 cm in diameter. Compare this to osteoblastoma. Grossly, osteoma is a circumscribed mass, usually red, and is composed of trabecular bone, usually less than 2 centimeters in size. Microscopically, is composed of thin spicules of osteoid and woven bone rimmed by osteoblasts. There is no significant nuclear TPS seen. Other benign bone forming tumors include osteoma. This is usually a solitary tumor, often seen in the skull, and it affects middle age. And it may obstruct sinus cavity, compress the brain or the eye. Osteoblastoma has similar features to osteoid osteoma, but it is more than 2 centimeters in size, and the pain is unresponsive to aspirin compared to osteoid osteoma, which usually affects the long bone. Osteoblastoma usually affects the spine. Now we go to the malignant bone forming tumor, which is osteosarcoma. This is the most common primary bone sarcoma, and it comprises of 20% of primary bone cancers. Osteosarcoma is usually seen in young adults. The peak incidence is around second decade of life. This is where the period of the most active skeletal growth is, but it has a bimodal age distribution. It can also be seen in the elderly. The anatomic site that is involved is usually the metaphysis of the long bones of the extremities. 50% occurs around the knee, affecting the distal femur and the proximal tibia. Males are affected more than females. 70% of osteosarcoma have acquired genetic abnormalities and is associated strongly with genetic mutation. like retinoblastoma gene or tumor suppressor P53 gene. Osteosarcoma developed at an increased rate in adolescents who had retinoblastoma as infants, where they have germline mutations in retinoblastoma gene, and patients with Li-Fraumeni syndrome, where they have germline P53 mutations. In the elderly, osteosarcoma is associated with Paget's disease of the bone. It can also be associated with radiation complication. In the early 20th century, women painted their watch with radioactive phosphorus. They licked the brushes that is covered by the radioactive phosphorus, and the radioactive phosphorus accumulated in their jaw bones, and these women developed osteosarcoma of the jaw. This also associated with bone infarct. The major sites of origin of osteosarcoma are shown in this picture. The most common site is around the knee. We've talked about it. It's where the longest bone and the second longest bone in the body is located. Other sites are the humerus, the pelvic bone, and the skull. Osteosarcoma has a characteristic feature on X-ray. It shows this sunburst appearance or Codman's triangle. The picture shows distal femoral osteosarcoma with prominent bone formation extending into the soft tissue, and you can see that at the arrow there is lifting of the periosteum by the tumor cells, and this is known as Codman's triangle. Grossly, this is what osteosarcoma looks like. This is osteosarcoma at the upper end of the tibia. The grayish white tumor fills most of the medullary cavity of the metaphysis and extending into the diaphysis. It has infiltrated through the cortex, lifting up the periosteum. That's where the Codman's triangle is seen, and it forms a soft tissue mass on both sides of the bone. Histologically, it is an osteoid producing tumor. You can see the osteoid, the pinkish material surrounded by the nucleus of the malignant osteoblast, and sometimes it's called the lace-like pattern deposition of osteoid. You can see that some mitosis is present, and the neoplastic cells are located in the spaces between the osteoid deposits. Osteosarcoma typically presents as a painful, progressively enlarging mass. It may present as sudden fracture as the site of bone is weaker than the normal bone. It can invade locally into the soft tissue or the surrounding organs and metastasize hematogenously to the lungs. 10 to 20% of patients have pulmonary metastasis at the time of diagnosis, and usually chemotherapy is given and then surgical treatment. So without chemotherapy and surgery, there is a very high mortality rate in osteosarcoma. Next, we look at osteochondroma, also known as exostosis. It usually affects people in the first 30 years of life, and it involves the long bones, especially around the metaphysis. It is the most common benign tumor of the bone, and it is a benign tumor forming bone and cartilage cap. It may be solitary or multiple, but if it is multiple, it can be associated with sarcoma. It may arise spontaneously or as a result of previous trauma. On X-ray, it shows a pedunculated bony outgrowth, and on histology, it shows mixture of bone with a uniform cartilage cap. Complications of osteochondromas include fractures, bone deformities, and most importantly, the malignant transformation, and treatment is resection of the bone tumor. Another benign cartilage forming tumor is chondroma, usually affects the male teenagers and young adults. It's usually seen at the hands and the feet, and it involves the metaphysis. Usually it's a solitary tumor, but if it's multiple, it is associated with Ollius disease, and this may undergo sarcomatous change. If it is associated with hemangioma, it is a Maffucci syndrome, and people with this Maffucci syndrome is at risk to develop other malignancies such as ovarian carcinoma and brain glioma. Other benign cartilage forming tumors are chondroblastoma and chondromyxoid fibroma. Chondroblastoma affects the teens. It involves the epiphysis, usually is painful, and recurrences are not uncommon after curettage or when the tumor has been removed. Pulmonary metastases occur rarely in lesions post-fracture or post-curettage. And chondromyxoid fibroma also affects the teens, and the site is metaphysis. It presents with dull pain, and it may recur, but there is no threat of malignant transformation or metastasis. Now we look at chondrosarcoma. It usually affects the elderly. Compare this to osteosarcoma. The anatomic site that is usually involved is the spine or pelvis or proximal parts of femur, and the part of the bone that is involved is the metaphysis. This is the second most common primary malignancy of bone. It usually develops de novo, but also may develop secondarily from enchondroma, osteochondroma, chondroblastoma, fibrous dysplasia, or Paget's disease of the bone. Grossly, we can see lobules of hyaline and myxoid cartilage spreading through the medullary cavity and growing through and through the cortex. And histologically, we see chondrocytes. You can see the bluish matrix of the cartilage, and the chondrocytes having the lacunae, and the cells, the nucleus are located in the lacunae. Clinically, chondrosarcoma, they present with deep, dull, achy pain, and the pain occurs at night usually. They also present with pathologic fracture. You can have nerve dysfunction, especially at the lumbosacral plexus or the sciatic or femoral nerves. And it is a slower growing tumor compared to osteosarcoma. It's graded from 1 to 3, and grade 1 tumor does not usually metastasize. Grade 3 tumors, 70% of them metastasize. Treatment is wide surgical excision again, and there's no role in chemotherapy in chondrosarcoma because they do not respond well to chemotherapy. Compare this to osteosarcoma, where usually in osteosarcoma the patients are given chemotherapy before and after the surgical treatment. Now we go to the fibrous dysplasia. Uh, this is a fibrous forming bone tumor. There are three types of fibrous dysplasia: monostotic, polyostotic, and polyostotic with endocrinopathies. Monostotic means it involves a single bone, polyostotic means it involves multiple bones, and polyostotic with endocrinopathies is usually associated with cafe au lait skin pigmentation, just like what's in the picture, and endocrine abnormalities, especially precocious puberty, pituitary adenoma, hyperthyroidism, and McCune-Albright syndrome. The danger is polyostotic lesions may develop sarcomatous change. Fibrous dysplasia is generally a well circumscribed lesion because it is a benign lesion, and histologically there are features of woven bone that is said to mimic Chinese characters, and the bone lacks prominent osteoblastic rimming. The malignant counterpart of a fibrous bone-forming tumor is fibrosarcoma. It is seen in middle-aged and elderly patients and occurs around the knee, and it involves the metaphysis. These are fibroblastic collagen-producing sarcomas of the bone. This malignancy usually arise de novo, but may also arise as secondary tumors in pre-existing benign tumors, bone infarcts, Paget's disease, or irradiated tissue. Grossly, these tumors are very large, hemorrhagic, intense white masses that destroys the underlying bone and extends into the soft tissue. Histologically, it shows this herringbone pattern of malignant fibroblasts, and clinically it presents as enlarging painful mass with or without fracture, and sarcomas arising from pre-existing lesions such as Paget's disease are more aggressive and has poorer prognosis. Next we move to giant cell tumor, also known as osteoclastoma, because there are osteoclasts scattered in this tumor. It usually affects young or middle-aged adults, and again, the majority of cases occurs around the knee, and it involves epiphysis, but it can extend to the metaphysis. Usually, it is a benign tumor. It's locally aggressive, but the malignant counterpart or malignant transformation has been reported in this tumor. On X-ray, it is an osteolytic lesion, sometimes called the soap bubble appearance. Giant cell tumors are believed to have a monocyte macrophage lineage, and the giant cells are believed to form via a fusion of the mononuclear cells. It rarely undergoes sarcomatous transformation, but has been seen and has been reported. This is a gross feature of giant cell tumor of the bone. You can see it destroys the normal bone tissue. It has spaces, the cystic spaces, which is filled with blood, and it just destroys the normal bone. This is located around the knee usually. Histologically, we can see numerous multinucleated giant cells in the background of the smaller mononuclear stromal cells. The stromal cells are actually the neoplastic cells in this tumor. It has poorly defined cytoplasmic borders and bland nuclei, and the nucleus resembles those of the giant cell nucleus. The multinucleated giant cells are non-neoplastic. Clinically, pain is the most common presenting symptom, and swelling and deformity are associated with larger lesions. Soft tissue extension is common. They may present with pathological fractures. 40 to 60% of the tumor recur after curettage. So after treatment, patients with giant cell tumor should be monitored, and 4% metastasize to the lung, even though the tumor is a benign tumor. So treatment, they sometimes are medically treated with denosumab, a monoclonal antibody against rancor, and it inhibits the binding to the rank receptor. So this drug prevents osteoclast formation. The other treatment is a surgical removal. That's the main method of treatment. One bone lesion that has similarities to giant cell tumor is aneurysmal bone cyst. It is a benign tumor of bone characterized by multiloculated blood-filled cystic spaces and may present as rapidly growing expansile tumor. It affects the metaphysis of long bones and vertebral bodies. Histologically, it can show similar features as giant cell tumors of the bone, because it has osteoclast type giant cells, has reactive woven bone, which can also be seen in giant cell tumor of the bone. Now we look at Ewing sarcoma or primitive neuroectodermal tumor. It affects mainly children and teenagers, and it involves the long bones, especially at the medullary diaphyses of the long bones. It is the second commonest bone cancer in children and adolescents. The most common bone cancer, as you recall, is osteosarcoma. It arises from cells with neuroectodermal differentiation. The majority of Ewing and PNET are associated with translocation 1122, where there is fusion gene that results in abnormal cell proliferation and survival. Grossly, the tumor affects the diaphyses of the long bone, especially in the marrow spaces. And here you can see the irregular tumor, the grayish brown tumor breaking through the cortex. Histologically, the tumor shows the small round blue cell features, cells that have hyperchromatic nuclei with scanty cytoplasm. Clinically, Ewing sarcoma presents as painful enlarging mass, which is tender, warm, and swollen. Ewing sarcomas often produce tender masses with fever and leukocytosis. So this can mimic acute osteomyelitis. It may metastasize early to the other bones. Metastases to the lungs, liver, brain, kidney, and other organs are common. 80% of the cases present with localized disease, whereas 20% present clinically with detectable metastatic disease. Treatment includes chemotherapy, surgery, and radiation. In the past, prognosis for Ewing sarcoma was poor, but with chemotherapy, about 75% of children survive 5 years. The most significant factor to determine prognosis in Ewing sarcoma is the presence or absence of metastatic disease. Primary site of the tumor is also a prognostic factor, distal extremities being more favorable than those with central or pelvic sites. Age less than 15 years old has a more favorable prognosis. The overall patient survival rate is around 60%. For patients with localized disease, the survival rate approach 70%. However, for patients with metastatic disease, the long-term survival rate is less than 25%. Metastatic tumors are the most common form of skeletal malignancy. Cancers can spread from other organs to the bone by direct extension or by lymphatic or hematogenous dissemination, or through the intraspinal seeding via the Batson plexus of veins. This goes through the paravertebral venous plexus, and this is a direct communication from the peritoneum and the lower body to the cranial cavity and spinal canal. The Batson plexus of veins represent an important pathway for metastasis. Any malignancies can affect the bone. About 75% of skeletal metastases originate from cancer of the prostate, breast, kidney, and the lungs. Any bone can be affected, but most commonly it is seen in the axial bones, the vertebral columns, pelvis, ribs, skull, and sternum, also in the femur and humerus. 3 types of metastatic lesion to the bone is seen: osteolytic, osteoblastic, or mixed osteolytic osteoblastic. Osteolytic lesions are seen where the cancer cells produce substance that can stimulate osteoclastic activity, such as parathyroid hormone related peptide. Prostate adenocarcinoma are osteoblastic, which is bone forming. Most metastases are mixed osteolytic and osteoblastic lesions. In adults, the most common cancers that spreads to the bone is the breast, lung, kidney, and prostate, whereas in children, the most common cancers that mets to the bone are neuroblastoma, Wilms tumor, osteosarcoma, Ewing sarcoma, and rhabdomyosarcoma. Metastatic bone lesions are typically multifocal. As you can see, the grayish lesions pointed by the arrows, except carcinoma of the thyroid and the kidney, which are usually solitary lesions. Prostatic adenocarcinoma tends to be osteoblastic, and renal cell carcinoma and breast carcinoma tends to be osteolytic. This microscopic picture shows the bone matrix. You can see the bone matrix at the left upper hand corner, and you see the multiple clusters of malignant cells showed at the arrows. Now we look at some soft tissue tumors. Soft tissue tumors are defined as mesenchymal proliferations that occur in the extraskeletal non-epithelial tissues of the body. They are classified according to the tissue that they differentiate into: muscle, fat, fibrous tissue, vessels, and nerves. In contrast to carcinomas, sarcomas usually metastasize via hematogenous routes, making the lung and skeletal tissue the common sites of dissemination. The nomenclature, if it arises from the adipose tissue and it's benign, it's called lipoma. If it's malignant, it's liposarcoma. So lipoma is the most common soft tissue tumor in adulthood, and rhabdomyosarcoma is the most common soft tissue sarcoma of childhood and adolescence. Soft tissue tumors and prognosis. Accurate histologic classification is important in establishing the prognosis of sarcoma. For many types of soft tissue sarcomas, the histologic grade is important. Remember, the grade 1 is it resembles the normal tissue, and grade 3 it has a poor differentiation. It does not resemble the normal tissue that well. Staging helps determine the prognosis and chance of successful excision of a tumor. So in general, tumors arising in superficial locations such as the skin, the subcutaneous tissue have a better prognosis than deep-seated lesions.